Hello everyone, my name is Tony Risha, and in this skull-based oncology case series, we will be discussing sinonasal mucosal melanoma. We'll first begin by discussing our case presentation. This is a 79-year-old male who presented to an outside hospital with symptoms of left nasal obstruction, facial pain, epistaxis, and ecchymosis. On clinical exam, he was found to have diplopia, left eye proptosis, and tenderness on palpation of the left cheek, along with left facial numbness. A flexible nasal endoscopy was performed and revealed a melanotic tumor of the left nasal cavity with significant amount of debris. A sinus MRI was ordered, which is an excellent imaging modality to define local disease extent. It revealed a large mass of the left maxillary sinus and nasal cavity, measuring almost 7 cm in its largest dimension. This mass invades the left inferior rectus muscle and the orbital apex. In addition, MRI of the neck showed a 2.2 cm left level 2 lymph node. An outside biopsy was performed and diagnosis came back as mucosal melanoma. On the picture on your left, you can clearly see the tumor with areas of necrosis. Immunohistochemistry studies came back as positive for S100, HMB45, and melin A. On the picture on your right, we can see a characteristic finding in melanoma, which is a loosely cohesive tumor cells growing around blood vessels in a peritheliomatoous fashion. A PET-CT scan was ordered to rule out distant disease and unfortunately showed disease in the pelvic nodes, the soft tissues of the left thigh, and the gallbladder. The patient was clinically staged as T4B N1M1 sinonasal mucosal melanoma. The different treatment options for this patient include surgery with without adjuvant therapy, primary radiation-based approaches, and immunotherapeutic or targeted agents. Our patient was initially treated at an outside hospital with radiation therapy. He received 5 treatments for a total of 30 grays, in addition to PD-1 blockade with nivolumab. Following local progression, the patient was transferred to our institution. There he was treated with a combined PD-1 blockade with nivolumab and CTLA-4 inhibition with ipilimumab. This post-treatment CT sinus shows a complete response after just 1 dose of ipi plus nivo. In this patient, we were able to perform molecular profiling to identify potentially favorable mutations, and in his case, we identified the NRAS G12A mutation, which may be associated with a better response to immune checkpoint inhibitors. Our patient, however, ended up developing treatment-related side effects consisting of diabetes, hypothyroidism, and autoimmune ocular disease. He passed away 18 months after treatment, likely related to complications of a pulmonary embolus. On this slide, you can see the latest NCCN Guidelines for treatment of sinonasal mucosal melanoma. The treatment options for locally advanced disease are surgical resection followed by adjuvant radiation. Alternatively, the patient can be enrolled in a clinical trial. For very advanced disease, treatment options include enrollment in a clinical trial, either primary radiation therapy or systemic therapy, or supportive care. When discussing surgery for sinonasal mucosal melanoma, the goal is complete surgical resection with clear margins. However, this is difficult to always achieve, mainly due to the complex sinonasal anatomy and proximity to critical structures like the orbit and the skull base. Ganley et al., in their series looking at malignant paranasal sinus tumors, included 53 patients with sinonasal mucosal melanoma with extension to the skull base who were treated with craniofacial resection. As you can see from the figure on your right, melanoma patients had the worst prognosis with a survival of 0% at 2 years. In addition, patients undergoing craniofacial resection had a 6% risk of mortality, and 26% of them ended up developing treatment-related complications. Because of these reasons, open craniofacial resection is no longer being performed at our institution for these patients. When it comes to endoscopic resection, Lund et al. In their single institution series of sinonasal mucosal melanoma showed that endoscopic resection had comparable outcomes to open approaches. Syed et al. Had similar findings that showed no difference in overall survival in patients treated by an endoscopic approach when compared to open resection. Evidence points that when feasible, endoscopic resection has lower morbidity, better quality of life, and comparable survival outcomes to open surgery. As we've previously mentioned, obtaining cleared surgical margins is paramount. However, a study by Amit et al., which was a large single institution study that included almost 200 patients with sinonasal mucosal melanoma, of which 86% were treated surgically, they found a positive margin rate of 22%, which demonstrates the difficulty with clearing margins for sinonasal mucosal melanoma, even with aggressive intervention. Should a neck dissection be performed with primary surgical resection? In general, a neck dissection is performed for clinically unpositive necks. However, the role of elective neck dissection in the N0 neck is ill-defined. Another study by Amit et al. Demonstrated that patients with clinically involved lymph nodes had similar outcomes to patients with N0 necks, and concluded that lymph node status is not a predictor of outcome in sinonasal mucosal melanoma. Moving forward to radiation therapy, multiple studies have looked into the role of radiation therapy in the treatment of sinonasal mucosal melanoma. Sam Stein et al. In his study showed that radiotherapy was able to improve local control in patients following surgical resection or in those with unresectable cancer, which is what we can see on the figure on your left. However, radiation therapy does not appear to improve survival outcomes in this patient population, as you can tell from the figure on your right. Grant Fremantle et al. Performed the largest meta-analysis looking at the effectiveness of radiation therapy in the treatment of head and neck mucosal melanoma. They looked at surgery alone and compared the outcomes to surgery followed by adjuvant radiation therapy, and again there was no observed difference in overall survival between these two patient populations. Systemic agents such as dacarbazine have been used in the solo setting but failed to show any improvement in survival. Recently, there has been a renewed interest in combining chemotherapy and immunotherapy, and multiple studies are currently underway. A notable characteristic of sinonasal mucosal melanoma that differentiates it from cutaneous melanoma is its high incidence of c-KIT and NRAS mutations and a lack of BRAF mutation. This specific molecular profile has led to investigations of using the tyrosine kinase inhibitor imatinib to target c-KIT mutations. Carvajal in his study showed a durable response, which is defined as partial response and complete response, in 16% of his patients. In this study, which you can see on the figure on your right, there was one patient with a partial response. This was the fourth patient from the bottom in light blue, and one patient with complete response, which is the last patient in dark blue. Guo et al. In a similar study showed a progression-free survival of 3.5 months when using the TKI inhibitor to target c-KIT mutations. In patients with NRAS mutations, the MEK pathway drives proliferation of melanoma cells. This is why multiple MEK inhibitors have been trialed in this setting with modest responses. In the NEMO trial, which is a multi-center, open-label, randomized phase 3 trial, it compared the MEK inhibitor benimetinib to dacarbazine in patients with NRAS mutant melanoma. And once again, there was no observed benefit in overall survival between these two patient populations. Finally, we'll discuss the role of immune checkpoint inhibitors in treating sinonasal mucosal melanoma. These have been shown to induce a dramatic response in advanced and metastatic cutaneous melanoma. Based on those findings, similar treatment strategies are currently being investigated in mucosal melanoma. Pastau et al. Conducted a multi-center retrospective analysis of 33 patients with unresectable or metastatic mucosal melanoma treated with ipilimumab and found an overall response rate, which is defined as either a complete response or partial response, of 6.7%. Shushtari et al. Looked at pembrolizumab or nivolumab, which are both PD-1 inhibitors for treating advanced or unresectable melanomas. They found an overall response rate of 23% when used in treatment of mucosal melanoma. D'Angelo et al. Looked at the combination of PD-1 and CTLA-4 inhibition versus monotherapy in mucosal melanoma. They found an overall response rate of 37% when used in combination, compared to 23% for PD-1 inhibition and 8% for CTLA-4 inhibition in the solo setting. However, they also found a higher grade 3 and 4 adverse events in the combination group, which was 40% when compared to 8% in the monotherapy group. To summarize, a recent single institution high volume center data assessed the outcomes over time with integration of endoscopic surgery, advances in radiation therapy and immunotherapy in the treatment of Sinonasal Mucosal Melanoma. And again, there was no changes in overall survival despite all of these advances. Regardless, the treatment paradigm of Sinonasal Mucosal Melanoma has clearly evolved. We have moved away from morbid surgeries, and with the integration of immunotherapy, we are observing clinical responses in many patients, but we have to keep the toxicity profile in mind. Current and future management of this disease will rely on advances of targeted and immunotherapeutic agents. However, the appropriate timing of integration of checkpoint inhibition remains unclear. Future studies are needed to analyze the impact of novel agents and protocols on survival outcomes and quality of life in sinonasal mucosal melanoma patients. Thank you everyone for your attention.